Hey students, we're going to quickly go over Chapter 20, Assessment of the Respiratory Function. This should be a review from previous courses that you've taken, so we won't spend a whole lot of time on it. It's just something that we're going to build on. So you should already be able to describe the structures and functions of the upper and lower respiratory tracts. You should be able to describe ventilation, diffusion, perfusion, and ventilation-perfusion imbalance, as well as explain, and you should be able to demonstrate the proper techniques used to perform a respiratory assessment. We will go a little more into normal and abnormal findings during your assessment, and then we'll talk mostly about diagnostic tests that you can use to evaluate respiratory function and how it relates to nursing and what part nursing plays in it. Okay. So again, exchange and respiratory function. You have to have perfusion, which is the blood. You have to have diffusion, which is your O2 and your CO2 moving, and then you have to have ventilation, and that's the oxygen actually coming in and the CO2 actually coming out. As far as findings, there's subjective findings, which come from your patient, and then there's objective findings, which are things that you find out, or diagnostics, things that are measured, quantifiable. Whenever you are speaking to your patient, you want to ask about, do they have a cough? If they do, is it productive? Is it non-productive? When does it occur? Is it worse in the morning, worse at night? Are they coughing after food or fluids? So if they're drinking and then they're coughing, or if they're eating and then they're coughing, then that can indicate aspiration. And then you would want to do further assessments. You'd probably ask for speech therapy evaluation and do a swallow study or swallow assessment. Ask them if there's any pain whenever they breathe. If so, where is it? Is there pain when they cough? Always go through, if you ask something that would give the patient an abnormal response. So if you say, are you coughing? And they say yes, that's not normal. So you would want to keep going. You always want to further investigate. So if they have pain, where is it? What's the quality? Is it intermittent? Is it continuous? Does it radiate anywhere? Okay. When does it occur? How severe is it? And I don't know if you guys use PQRST or not, or if you use a different type of assessment technique with chief complaints and getting a patient history. But PQRST is just the position or place. Q is quality. R So as far as assessment goes, you're going to ask the patient, are they coughing? Are they not coughing? If they are coughing, is it productive? When does it occur? Is it worse in the morning or at night? Does it cause pain when they cough? Are they coughing after certain events? So are they drinking and then coughing? Are they eating and then coughing? That would indicate aspiration, and we'll talk about that in a different lecture. But aspiration is whenever the fluid or the food goes down into the tracheobronchial tree instead of going into the esophagus like it's supposed to. So then you would want to get probably speech therapy involved, do a swallow study, swallow assessment. If the cough's productive, what color is it? What's the amount? So keep going with your assessment to find out as much as you can. If they have pain with the cough, where is it? What makes it better or worse? So think about your chief complaint. Anytime you get anything abnormal, then you're going to continue down that path. I don't know if you guys have been taught PQRST with assessments, but basically the P is palliative or provocative factors. So what makes the pain better or worse, or what makes your cough better or worse, what makes your shortness of breath better or worse. So whatever the complaint is there anything that makes it better? Is there anything that makes it worse? Q is quality. Well, is your cough productive? Is it non-productive? Some people will say it's like a tight cough, or they'll say it's a real just wet, loose cough. So how are they going to describe the quality of whatever their complaint is? Region, where is it happening? Radiation, does it radiate anywhere? Severity, how bad is it? So some people might cough once or twice. Some people might have a 5-minute coughing spell. So how bad is it? And then when does it usually happen is timing. PQRST, you might have heard of PQRST-U. The U is how is it affecting your life. So the U is all about the patient. Sorry, that was a side note, but during an assessment, if you can keep all of those things in mind, you'll usually get most of the information out of your patient that you need. And then each system, there's specifics that you would need to go into. Are they short of breath? When are they short of breath? Is it after activity, after conversation, when they try to eat, when they lay down, they have more shortness of breath, or difficulty breathing? So, when exactly is it happening? How long does it last? Dyspnea can be related to a pulmonary condition, respiratory condition. It can also be related to cardiac conditions. People who have anemia can get short of breath or have difficulty breathing. It can also be related to neurological disorders, trauma. So you really need to find the cause, especially if the only thing they're complaining about is shortness of breath. And then look at their breathing pattern and their respiratory rate. Is it high? Is it low? Do they have orthopnea? Orthopnea can happen with COPD or heart disease. Tachypnea can be reactive airway disease. It could be respiratory distress. It could go along with them complaining of dyspnea. They could have a partial airway blockage if they have orthopnea. Hemoptysis is whenever they cough up blood from the respiratory tract, and there are different causes for that too. Sometimes they're just coughing so much they burst capillaries. Other times it could actually be due to a condition. Do they have any periods of apnea? If they do, how long does it last? When you're listening to their lungs, are they clear? Do they have adventitious lung sounds? If they do have adventitious lung sounds, then what are they? Are they wheezing? Are they rhonchi? Are they crackles? Do you hear a friction rub? Do you just hear diminished lung sounds or no lung sounds in a certain part of the lung? Make sure you assess the anterior, the lateral, and the posterior lung fields. If a patient is laying down and you need to do an assessment, they have to sit up or they have to turn over. You have to get to those posterior lung sounds one way or the other, because that's where you're going to get most of those lung fields. And you're really going to be able to see if there's any adventitious lung sounds deeper down in the lungs. So the fact that they're completely dependent and they're laying on their back is not an excuse to not assess their lung sounds. If they say that it hurts to move, that's not a reason to not listen to their lung sounds. Your assessment is a primary responsibility. It has to be done. It has to be done completely. You can't just bypass part of it because if you're afraid that the patient won't like you afterwards, or the patient doesn't really want to move. What you can do is don't just turn them over to listen to their lungs. Turn them over, reposition them, clean them up, do it during other tasks that need to be done, but it still needs to be done. Also look at their hands, look at their feet. Do they have clubbing in their fingernails? Do they have any cyanosis? So look at their skin, look at their lips, look to see if there's any pallor. Do they look pale? When they take a deep breath, look at chest symmetry. Look at the shape of the chest to see if you notice any type of abnormal, like a barrel chest, pigeon chest. Kyphoscoliosis occurs with severe scoliosis. Do they have funnel chest? And are their breaths deep? Are they shallow? Are they rapid? Are they slow? Are they regular, irregular? You're going to look at all of that. You're also going to get a health history and include anything that could affect the respiratory system. You can do diagnostic tests and then look specifically at the respiratory rate and pulse ox for vital signs. As far as a health history, make sure you get the chief complaint. So what is the history of their present illness? Look at their onset, location, duration, character. Again, PQRST, any aggravating or alleviating factors. What is the timing of it? Is it constant? Is it intermittent? Is it after they do something? Is it radiating? And then any associated symptoms. You also want to ask how it affects their daily activities and how is it affecting their life. Have they had to alter the way they do things because of it? You want to find out the history as far as has this happened before? So is it something more chronic or is it acute? Have they been hospitalized before? Ask them about childhood illnesses because that can affect the respiratory system. Ask them about their immunizations, make sure they're all caught up. Do they have any chronic conditions and maybe not related to their current complaint? That's still important to know. Do they have any kind of allergies? Have they had surgeries in the past? What medications do they take? Both over-the-counter herbal supplements, oral tablets, injections, nasal sprays, eardrops, eye drops, inhalers, nebulizers. Sometimes you have to be specific with your patients because if you ask them about medications, they think about pills prescribed by the doctor. Are they smoking? Do they use illegal drugs? Smoking is the single most important contributor to lung disease. So if they are smoking, how long have they been smoking? When did they start? Do they plan on stopping? Are they interested in stopping? How much do they smoke in a day or a week? Really get into it. What type of cigarettes? Are they menthol, non-menthol? Are they smoking but it's not cigarettes? So get very specific. Pulmonary testing. Pulmonary function tests, or PFTs, you can look at table 28 to get more information on them, but they're used to help diagnose chronic respiratory conditions, and they can be done in the pulmonologist's office, and they'll be done by either his medical assistant. They might have a respiratory therapist in there, but generally it's an assistant or a tech that does it, and then they give the results to the physician to interpret. When you look at the results of the pulmonary function test, the doctor will take into account their patient's age, as well as their gender, their height, their weight, their ethnicity, because that all affects tidal volume and other what we would consider normals, because when you're looking at pulmonary function tests, you're looking at how far away from the norm are their results. You can also have ABGs. Those are arterial blood gases. And just as it sounds, you are getting a blood sample from an artery, and it assesses the lung's ability to provide adequate oxygen and then remove carbon dioxide. So you're looking at the diffusion process that happens in the alveoli. ABGs will also tell you if the kidneys are able to excrete and reabsorb bicarbonate, and it will tell you if the body has been able to maintain normal pH and homeostasis. Blood sample, again, always obtained from an artery. It can be done by a physician. It can also be done by respiratory therapists. They will draw the sample, put it on ice, and have it sent to the lab for interpretation, and it has to be done fairly quickly. It is invasive, so it's not something you want to do all the time, only whenever it's necessary. A pulse ox is non-invasive. Pulse oximetry is a machine, and it can monitor oxygen saturation in the hemoglobin. So it is not the same as an ABG, but it can look at the number of oxygen molecules that are on the hemoglobin. It's very effective for monitoring subtle changes in the saturation of the oxygen. It can be inaccurate if you have poor perfusion of if it's on the finger or the toe for pediatrics. You can also put it in the earlobe. Some people will have it on the bridge of the nose or the forehead, but you have to have adequate perfusion to that area in order for it to be accurate. You generally want to put it on a nail that does not have nail polish on it. If the patients move, that can affect the reading as well. So the best reading is the one that they're sitting and resting, unless you're trying to see what happens whenever they ambulate, if there's a drop in the sat or not. But it is non-invasive, and so you can get a pretty good reading that, along with other clinical findings, can tell you if their oxygen saturation levels are low or not. You can do sputum tests, and this is done if they think that there is some kind of an infection, so they can identify the appropriate pathogen, and then they know what kind of treatment. You can also do a chest x-ray that gives you a good basic picture of the lung, and it's usually done AP and lateral, so it's done two different positioning. The patient will position two different ways. They'll face forward, and then they'll turn on face and get a sideway view. And the patient will be asked to take in a deep breath, let it out, take in a deep breath, and hold it to expand the lungs as much as possible to get the best picture. And that will identify if there's any kind of consolidation within the lung, if there's any fluid in the lung, or if there's a mass. So it can tell free, open space, and then density. A CT is better. It provides cross-sectional views, and it can distinguish fine tissue density. So if there's any kind of small tumors, small nodules, if you use contrast, it can also look at the vasculature to see if there maybe is some kind of an obstruction or narrowing in the vasculature that's affecting perfusion. With the CT, the patient has to be able to lay still in a completely flat or supine position. It can cause some anxiety because they are going in the machine. They can be medicated if this occurs, but the CAT scan generally is a quicker exam. They do have to be able to hold their breath again multiple times. And so that's another thing. And they usually have to be able to put their arms over their head. MRI takes longer, but it can give a better picture than a CT. It can take 60 to 90 minutes, where a CAT scan you can do in maybe 10 to 30 minutes, depending on how the patient is able to tolerate laying still. Okay. It does better distinguish, the MRI better distinguishes between normal and abnormal tissue. Because it is an MRI, they use magnetic fields, so the patient can't have any metal on or in his body. And otherwise they won't do the exam. They can do a fluoroscopy. This is invasive. A camera will project on a video screen, and it's used with the chest needle biopsy or transbronchial biopsy to identify lesions, so it can give them a visual picture going in through the trachea to the bronchial tree. Pulmonary angiography is a visualization of the pulmonary vessels. With this, a catheter is inserted into a vein, and then it is threaded into the pulmonary artery. Then they inject a radioactive dye, and then they do the imaging. It can't be performed if your patient is allergic to shellfish or iodine because the radioactive dye, they'll have a reaction to it. Same thing with your CAT scan. You can't have contrast if they're allergic to iodine or shellfish. Okay. Before you can do the angiogram, you have to get bleeding times. So you have to do the coag studies to make sure that they have enough platelets and that they don't have excessive bleeding times. If their INR and their PTT are high, then the physician needs to consider the potential for complications. You also want to look at their renal function, because the radioactive dye needs to be excreted as quickly as possible through the kidney. If you have kidney impairment, then that doesn't happen, but it can also cause some kidney damage. Your patient has to be NPO for 6 to 8 hours. You don't want them to have anything in their stomach that they could could come back up the esophagus and cause aspiration. The patient will be awake. Make sure that you let them know whenever the dye is instilled into their vein. They're going to feel this warm to hot flushing sensation. They might actually feel pain in their chest as well. So their chest will be warm, it'll be hot, and they can feel what some people describe as pain. It should go away once the dye is not in, the injection stops. Okay. If they require arterial puncture to do the exam, the affected extremity has to be immobilized, and the nurse needs to closely monitor the patient's vital signs, level of consciousness, oxygen saturation levels, as well as the insertion site or the puncture site to make sure that they don't have any bleeding or hematoma. Neurovascular checks are also done as well in that extremity to make sure there was no nerve damage done. Lung scans, you can have a VQ scan, and that's an injection of a radioactive agent into a peripheral IV. And it looks at the measurement of blood perfusion through the lung, and then the ventilation is checked by the patient breathing in and out oxygen mixed with radioactive gas agents. And then they do more exams that way. So first they put it through your peripheral IV. That's going to check perfusion, and then the ventilation is checked whenever they breathe in and out with the gas mixture. Okay. You can also have a gallium exam. Gallium is also a radioactive agent. And the gallium is injected into the IV, and then the scan's performed at different intervals. So they'll inject the gallium, and then they'll do scans, and then they'll say, okay, come either sit there or come back in an hour, then 2 hours, and 4 hours, 24 hours, depending on what exactly they're looking for. You can also have a PET scan, and that's a positron emission tomography scan. And this detects metabolic changes in the tissue itself. It can show regional blood flow. It is more accurate than a CAT scan in showing malignancies because it can detect metabolic changes in the tissue. It can actually see death of the cells or if cells are dying. The patient needs to have an empty bladder. They have to be NPO for at least 4 hours. They need to avoid alcohol, tobacco, and caffeine for 24 hours prior to the exam. And after the exam's done, they need to drink plenty of fluid so they can flush out the isotopes. A bronch or bronchoscopy is whenever you need to have direct inspection and examination of the larynx, trachea, and bronchi. And it's performed using a bronchoscope. They can also obtain tissue and sputum samples through a bronchoscopy. It's used also to find if they have hemoptysis and they can't really figure out what's causing it. They can go in and see if they can figure out like where the bleed is coming from. You can use it to remove a foreign body if they have some kind of obstruction or partial obstruction. As far as nursing, before the procedure, make sure you verify informed consent because it is an invasive procedure. Your patient must be NPO 4 to 8 hours prior to surgery. They have to remain NPO until the gag reflex is back because they do go under general anesthesia, and because they're going into the airway, you want to make sure that they don't have any aspiration, which is why they're NPO beforehand. You will administer a sedative or opioid as well as atropine, and the atropine inhibits the vasal stimulation and suppresses the cough reflex. You are going to monitor the respiratory status. They might have a productive cough with blood-tinged sputum that's normal. They can also have a slight fever because they're going in and irritating the airway. It is triggering the inflammatory response. So the first 24 hours, if they have a fever, and as long as it's low grade, it's normal. After that, you would want to notify the physician. With the bronch, lidocaine can be sprayed into the pharynx. It can also be dropped on the epiglottis, as well as the vocal cords and into the trachea. And this is also done to suppress the cough reflex and minimize discomfort during the bronchoscopy. If you do, not you personally, but if your patient gets lidocaine during their bronch, then you need to make sure that you watch for a good gag reflex, good swallow reflex, and that they have feeling back in that area. After the bronch, you're going to assess for any confusion or lethargy, especially in the elderly. And that could be because they're given too much lidocaine during the procedure. So make sure you really watch to see that they're not confused, not lethargic. With a thoracoscopy, you actually use a scope to go into the pleural cavity. You can get samples of tissue, fluid can be obtained as well. As far as nursing, it is invasive, so you have to check for the informed consent. They have to be NPO before the procedure. After the procedure, you want to make sure you monitor their respiratory status, listen to their lung sounds, respiratory rate, their depth and depth of respirations as well as rhythm. Look at the post-op site for initially signs of bleeding or hematoma hemorrhage, and then also signs of an infection. The doctor can place a chest tube drain, and if they do that, then you need to do all the monitoring of your chest tube drainage system. Thoracentesis is when they aspirate fluid or air from the pleural space. It can be diagnostic, so that gets sent to the lab to figure out what exactly is in the pleural space that shouldn't be there. It can also be therapeutic if the patient is having trouble breathing because of the excess fluid. And then you can also have biopsies, and this is when they remove a small amount of tissue. They can do this during the bronchoscopy, during the thoracoscopy. They can do it during the thoracentesis. Generally, that's just fluid. But the nursing interventions obviously monitor the site for bleeding. If they did a bronch and they got samples, you're going to monitor for bleeding, see how much they're swallowing. If they're coughing up a large amount of blood, that's not normal. Blood-tinged sputum is normal the first 24 hours, but not like actual frank blood. They could have shortness of breath. And then you're also going to watch for infection at the biopsy site. If they do have bleeding and the biopsy was taken within the bronchioles, you'll actually hear the fluid in the lungs, the crackles.